Welcome to this session on the essentials of hospital infection control, focusing on specialized practices within the intensive care unit. We will move beyond just treating disease to architecting a complete safety environment for the critically ill. The ICU design protocols presented here emphasize maintaining clear zones around patient beds and managing specialized airflow paths to minimize risk. The reality of healthcare-associated infections, HAIs, varies significantly between global regions, with high-income countries seeing a 7% prevalence, while low- and middle-income countries face rates up to 19.1%. In adult ICUs within developing nations, as many as 1 in 3 patients acquire an infection, leading to an excess hospital stay of 5 to 29.5 days. These infections are the primary driver of preventable mortality, with ventilator-associated pneumonia, VAP, carrying a 29.3% mortality toll, followed by CLABSI at 23.6% and CAUTI at 18.5%. We must also confront the escape threat, which includes pathogens like MRSA, VRE, and CRE that flourish under selective antibiotic pressure. Minor populations of these resistant organisms slowly replace susceptible strains when contact and antibiotic pressures are high. Emerging threats such as Stenotrophomonas maltophilia and Acinetobacter baumannii represent the ongoing evolution of these clinical challenges. Our first layer of defense is standard precautions, built on the universal logic that all blood, body fluids, and non-intact skin harbor infectious agents regardless of patient status. This layer integrates 4 critical components: the use of personal protective equipment, PPE, the safe management of sharps, routine environmental disinfection, and rigorous biomedical waste management. Hand hygiene serves as the central hub, connecting all these protective actions. Effective hand hygiene follows a spatial workflow known as the 5 moments, occurring before patient contact, before aseptic procedures, after body fluid exposure risk, after patient contact, and after touching patient surroundings. For routine rounds with no visible soil, a 20 to 30-second hand rub is the standard method. However, a 40 to 60-second hand wash is mandatory when hands are visibly dirty or when there is a suspected spore exposure. Difficile. Layer 2 introduces transmission-based precautions, TBP, which are targeted isolation strategies applied in addition to standard precautions. These should be initiated as soon as there is a clinical suspicion, rather than waiting for laboratory confirmation. TBPs are categorized by the vector of spread: contact, droplet, or airborne. The transmission matrix helps us adapt our defense to these specific vectors. Contact precautions for culprits like MRSA or CRE require gowns and gloves, while droplet precautions for pathogens like pertussis require a surgical mask within 3 feet of the patient. Airborne precautions for M. tuberculosis or measles necessitate a fit-tested N95 respirator and placement in a negative-pressure airborne infection isolation room, AIIR. Layer 3 addresses the point of vulnerability, focusing on device-associated infections where medical tools bypass natural host immunity. Extreme interventions in the ICU require extreme protocols to prevent VAP, CLABSI, and CAUTI. We employ the care bundle philosophy, which uses structured groups of evidence-based interventions that produce better outcomes when executed together than they do individually. Defending the airway involves the VAP bundle, which targets the endogenous aspiration that often occurs within 48 to 72 hours of intubation. The maintenance checklist requires elevating the head of the bed to 30 to 45 degrees and providing daily oral care with a 2% chlorhexidine solution. Additionally, clinicians must perform daily assessments for extubation readiness while providing prophylaxis for peptic ulcers and deep vein thrombosis. Defending the bloodstream through the CLABSI bundle is divided into insertion and maintenance phases. On day 0, clinicians use maximal sterile barrier precautions and chlorhexidine skin antisepsis at the optimal site, avoiding the femoral vein in adults. Daily maintenance requires scrubbing the hub with alcohol or chlorhexidine before every access and removing unnecessary lines immediately. Defending the urinary tract involves the CAUTI bundle, noting that the risk of bacteriuria increases 3 to 10% for every day a catheter is in place. The risk reaches nearly 100% after 1 month, making prompt removal the best defense. Proper care includes using catheters only for strict clinical indications, maintaining a closed drainage system, and ensuring unobstructed flow with the collection bag below the bladder. Layer 4, Overwatch, focuses on active surveillance rather than passive lab reports. While passive surveillance is prone to missing data and lacks clinical context, active ward liaison surveillance involves daily physical visits by infection control nurses to the ICU. These nurses prospectively collect data on device days and specifically hunt for VAP, CLABSI, CAUTI, and surgical site infections, SSI. To decode our performance, we use the clinician's dashboard to track 2 primary metrics, DUR and SIR. The device utilization ratio, DUR, measures exposure by dividing device days by patient days, where a high DUR warns of over-reliance on invasive devices. The standardized infection ratio, SIR, compares observed infections to predicted infections based on national baselines. An SIR under 1.0 indicates the unit is successfully beating the national average. Systemic overwatch also includes antimicrobial stewardship, AMSP, to prevent the proliferation of the escape pathogens. This cycle begins with diagnostic stewardship, sending cultures before starting antibiotics, and proceeds to empirical therapy based on local antibiograms. The critical step is de-escalation at 48 to 72 hours, where clinicians switch to narrow-spectrum agents or oral medications whenever possible. In summary, the complete defense architecture integrates point-of-vulnerability defenses with universal and vector-based precautions. Infection control is not just an administrative task. It is the most critical physiological intervention performed in the ICU. By following these protocols, we stop merely treating disease and begin to truly architect safety for our patients.